got to bring in Dr. Tyson. And we had a lunch and learn this afternoon, and he was like, put me to work. And so Paula arranged for him to be here, and we're so glad that you took the time, because I know it's a Friday. At least there's cookies, to come and learn some more. But I'm just gonna, I don't know if you read a bio, but I'm just gonna read a little bit of Dr. Tyson so you know kind of who is in front of you today. I actually had the pleasure of hearing Dr. Tyson in 2010. I went to a conference in New York, and he was presenting there. Actually, it wasn't medical, it was about how to battle insurance. And so not only is Dr. Tyson a skilled physician, but he's also a really powerful advocate for families and for those who suffer from eating disorders and their families. It's a really huge battle with insurance, which it's really, for me, it's a social justice issue. I'm a daughter of someone with an eating disorder and a mother of someone with an eating disorder. And just having seen the fight that I've had to do to get treatment for my daughter, and then there's people that are just completely forgotten, and really that insurance companies are planning on really just that they would just die. And so since they're better, I fight for them. So we're trying to educate physicians and nurses. So the fact that you're here, I'm hoping that it will change your practice and that you will in turn educate people around you, and that we can start to change the tide of the way the world and the medical world especially treats eating disorders. So I'm really glad you're here. And this is pretty much my passion. So I'm going to shut up and talk about Dr. Tyson now. Dr. Tyson has been specializing in the treatment and assessment of eating disorders in his family practice for over 25 years. I'm not going to talk about, he's just really qualified. He started out went to school in Oklahoma, and now practices in Austin. He is a member of the Academy of Eating Disorders and the International Association of Eating Disorder Professionals and the National Eating Disorders Association, among other organizations. He's also on the advisory board of the Academy of Eating Disorders, and wanted you to know that the Academy of Eating Disorders has medical guidelines for practitioners, and he was one of the co-authors of those, and those are available online. I think he has a reference to those. Mm-hmm. So not only that, but having a private practice, and he treats men and women with every type of eating disorder. He also speaks nationally and internationally on the subject of eating disorders. And top of that, he advocates, he's been to Washington, D.C., he's going to be there in September, speaking before the Senate on behalf of the Anna Weston Act, and you can look that up. And then he also lobbies in Texas, which is really hard, because I think Texas is a little behind the curve as far as mental health reform, which I don't know if you guys know this, but Missouri is actually really ahead of the curve. Yep. So if you stay in Missouri, Moeta in St. Louis has really pioneered for fabulous legislation for insurance to mandate coverage for eating disorders. So that's in our favor. So please welcome Dr.
Thank
Edward
you.
Tyson.
Okay, good. All right. I really appreciate your being here too. Friday afternoon, I know probably what I would have done. So thank you for being here. Y'all must be all the A students, or the brown nosers, one or the other. So thanks a lot for being here. I think you'll get a lot out of this today because it's a challenging thing. If probably the most complicated illness you'll encounter in your practice will be someone with an eating disorder. Now, if you're somebody who likes coughs and colds and runny noses, this is not really probably for you, but at least you should know whom to refer and what you're seeing so that you can at least ask for help like anything else. But they're challenging, they're incredible, and I think hope to get you at least engaged in thinking about people who come in with eating disorders in a different way than you might have before. Okay, I usually put this on academic lectures because they want you to tell you who your possible disclosures are. I am on the faculty of Shire Pharmaceuticals, who makes Vyvanse, which has been recently approved by the FDA for treatment of binge eating disorder. That's all I'm going to say about it, but unless there are questions, I can do that. The advantage of something like this is if I speak on Shire's behalf, I have to follow exactly what the FDA says. I can't make any other comments about my clinical experience, yada, yada, yada. So anyway, all right, so clinical cases. Okay, first of all, this is a 27-year-old who came into my office in Houston, referred by a psychologist at the Obsessive Compulsive Disorder IOP program in Houston for medical clearance due to her emetophobia. How many of y'all have heard of that? It's a fear of throwing up. And I've had 2 patients who had to be hospitalized for that. And both of them had the experience in very early age, like pre-K, something like that, saw somebody throw up, and ever since then, they're horrified of it. I don't know about you, but I don't like to throw up. I'll do anything to do that, to not do it. But it's not one of these things where it keeps me from eating. Anything that looks, sounds like, smells like, could possibly in any way make her feel nausea, she stays away from. And she says she's had nausea all of her life, but it's gotten worse over the last 2 or 3 years. She had a workup at the Mayo Clinic. A lot of people think that's what you do when you want the best workup. Anyway, they did an upper-lower endoscopy, the things you would expect, a gastric emptying study, lab, and so on. And reportedly, she was told that she had some slowed digestion, even though her emptying study was reportedly normal. A GI doctor, I can't remember if it's the one there or not, told her she needed to try a gluten-free diet and also a short-chain carbohydrate diet. Now, she's got OCD. What do you think she did? Exactly what they said, to the letter. Now, if somebody who already has a constricted diet, and now you constrict it even farther, you're really starting to put a bind on somebody when you think about, okay, where are you going to get your protein, your fat, and your carbohydrate, and your calories? What's going to do it? Interestingly, she developed nightmares and night sweats as soon as she started the OCD program. I'll let y'all ponder why that might be. Her only complaints were very early satiety with very restricted amounts of food, of those foods that she would eat, which was very limited, and she could only allow herself to have 2 meals a day and nothing before 8 a.m. and nothing after 6 p.m. So that means she goes 12 plus 2, 14 hours of the day without any food and going in. So think about how the body reacts to that. What does the brain do when you don't have food for 14 hours? Does it start to take protective measures? Does it try to tell you to eat or whatever? And if it does, how does that manifest itself? Ponder that for a bit. She was absolutely adamant that she did not have any eating disorder. She said, I don't have any body image issues, and I recognize I'm thin, and I don't want to be thin. She has regular periods, and she's using the NuvaRing for birth control. Other complaints were fatigue, feeling cold, and she would have episodes of palpitations and also some chest pain that she would describe as a tight pressure in her chest. So, anything just on this, and trust me, I'm not trying to pimp you here, but if you've got questions or you have thoughts and wondering, I want you to kind of be, how many of y'all watch House or used to watch House? Now if you've got, could it be? I'm not going to shame you. I went to medical school and I remember I wasn't about to answer a question in public, but I'm not going to do that here. So if you've got questions or your thoughts, could it be this or whatever, I'm game. Anything on this sound especially alarming to you? Anything set off something in your head or get this, you go, oh, okay. How about, if not, what do we do next? How about an exam? She was cooperative and articulate, but notably anxious. Did not really want to be there and be examined. She wanted to just do the OCD program. She was very upset. They made her have a clearance because she said, there is no way I can eat more unless I'm in the OCD program. The OCD program says, if you're that medically unstable, we can't have you in the program. So she's in a dilemma, and she establishes in front of you, as a clinician, a dilemma. What do you do? She's 5'4", 98.7, a BMI of 16.1 because she's 94 pounds, and for a 27-year-old, that is low. About 3 years prior, she was 118 pounds and a BMI of 20.25. So over the last bit, not only has her emetophobia increased, her weight and nutrition has gone down. Here's a little learning tip. The more the malnutrition, the worse they are about willing to eat. It becomes that if I drop to here and I constrict my diet here, that is the absolute maximum. Then when they drop it some more, that's the absolute maximum they'll do, and so on and so on. And they get worse and worse. Malnutrition does not beget hunger. After a fairly short period of time, malnutrition begets more malnutrition. Doesn't seem to make sense. Seems like one of those biologic paradoxes. There could be some rationale for it, which we can talk about. But laying down supine, her pulse was 96/58, and her pulse was 72, but it was weak. When she stood up, her blood pressure was 102/96. What do you think of that pressure? 102/96. Is that normal? Good? Bad? What's bad about it? Well, 102 to 96 is a 6 millimeters of mercury pulse pressure. So that's, if you take a blood pressure cuff sometime and just try to do 6, it's very hard just to do 6 millimeters. That's the difference between your compression, the pressure there from a squeeze, and the relaxation pressure when she stood up. So you think, okay, how's she getting blood to her brain? If she exercises, what happens then? Well, are there other areas? What about her kidneys? What about her coronary arteries? And come to think of it, she was having tightness in her chest and shortness of breath or stuff. So, maybe this is related. Her pulse went up to 88. It was weak, it was thready, and she had a temporary, what she called a blackout, where things went black. When somebody tells you that, the translation is they're not getting blood to their visual cortex. Is that normal? No. And is it normal in a young adult? No. And it's the same thing. What if it was in the heart when you didn't get enough blood flow to the heart? What do we call that? Chest pain, what do you call that? Angina. Hey, very good, angina. That's right, angina. The brain doesn't have the pain fibers, so she doesn't feel the pain. She just gets the dark going on, and she says, oh, it'll pass. When people get chest pain, they usually don't go, oh, that's no big deal. Usually people get anxious, but the brain doesn't hurt. So her thyroid was very thin. She had muscle wasting throughout, bitemporal, periscapular, periclavicular, pelvic, and everywhere else. Intercostal, intermetacarpal wasting. And her PMI was weak, and it was shifted medially. So PMI is normally about 60 degrees, about 4th to 5th intercostal space, right along the bra line, for those of you who wear bras. And the heart sits at a 60-degree angle. Now, when you have heart failure, what happens to your PMI? You get a bigger chamber, remember? And it starts to move over to the left. You start feeling a cardiac pulse more over here. But with malnutrition, the left side of the heart has more muscle than the right. And when you lose muscle mass, you lose more volume on the left than you do the right, and you get a more vertical orientation. It gets weaker, and you also get a smaller chamber size. So to do the same work, like going lying to standing now, her heart's not only weaker and smaller, it can't pump as well. So her skin, she had notable acrocyanosis and capillary refill delay. Are y'all at the point where y'all know what that is? Squeeze your fist, open it. How fast does the pink come back? Within 2 seconds is generally considered normal. And hers was about 15, seconds. She was blue, hands, fingers, feet, and she had a definite cyanotic hue. Her ECG showed low voltage, and yet somebody with a thin chest wall, you shouldn't have low voltage as a young adult. It's because she has very little heart muscle mass. A vertical axis consistent with that, and she had a junctional rhythm. She refused to do lab work because she said, I would rather die than have a needle stick. And I mean, she was adamant, and rather die than throw up. She said, that's why I have to be in this program. It's the only time I felt like maybe I could get through this, was in this program. So she eventually did, because we told the parents, I mean, she really has to be in a medical stabilization unit that specializes in this. And the parents were saying, but she's not going to do it. She's going to refuse. Can't you just approve her for the OCD programs? And I said, tell you what, let me just get the lab work. Can she get the lab work? So she waited till Wednesday after that Saturday phone conversation with the parents and her. She finally got it. And the only things that we found on this that were notable: a low vitamin D, an increased iron binding capacity, and her estradiol was undetectable. Why is that unusual in her? What medicines was she on? She was taking the NuvaRing, which has ethinyl estradiol in it. That's one of the ways it works. And normally she should have estradiol. That's normal. It's like testosterone in males. She has undetectable levels of estradiol, even with being given estradiol. Very common in malnutrition to lose your sex hormones, even on birth control pills. Okay, so we told her, you need to go in. This is serious. No, can't do it. Can't do it. We gave her warnings about refeeding syndrome and hypoglycemia and all that. And then 3 days later on a Saturday, she called the PA who works with me in Houston. I feel terrible. I need to go to the treatment program. I'm ready to go. We said, you got to go to the ER first, but tell them to do a phosphorus, magnesium, and be sure they do your electrolytes. Because they're going to tell you that you're having a panic attack, and you've got to insist on this. She goes to the ER, and the doc said it was a panic attack and they were going to discharge her. She and her parents insisted on getting a phosphorus, etc. They checked the phosphorus, and there's its level, 0.8. None of y'all who know much about this maybe don't know how bad that is, but hypophosphatemia can cause sudden cardiac arrest. Phosphorus is the element that you need in ATP. You remember your biochemistry of the cell? What does that do? That's what runs it. You break off the last phosphate, you get energy released. What if you don't have any more phosphorus? Then your more energy-needing cells, the higher metabolic cells, start to falter. Those would be brain, so they can have delirium, usually about 2 weeks into refeeding. And next, red cells, they start breaking apart. You get red cell hemolysis. Muscles, rhabdomyolysis can occur, and then the most important, cardiac muscle. And then you can have sudden cardiac arrest. They can go into usually torsade, and then just, it can happen in a few seconds without warning. So as refeeding syndrome is what she had. The ER admitted that they had never seen a phosphorus that low. What did they do? They did not admit her. They kept her in the ER, gave her phosphorus IV, and the next night, on Sunday, they discharged her. But they refused to give a prescription to her for phosphorus. Have no idea why, didn't explain it. Next day, Monday morning, she shows up at the office feeling horrible, sweaty, shaky, hot, could barely move her legs and her arms. She had an overpowering sense of doom. She kept asking, am I going to die? Am I going to die? She looked terrified, couldn't move her arms. She needed assistance and almost passed out just trying to go to the bathroom. Called EMS. They said, oh, no, there's a panic attack. No. You take her back to this hospital and you tell them, again, phosphorus and all that. And bingo, they go, and this time she had another phosphorus of 0.8. Lesson here is malnutrition, the phosphorus doesn't recover like that. You have to give phosphorus stores, and that takes some refeeding. But refeeding also makes refeeding syndrome more likely. So you have to do this balance of how much calories you give, and the way you do it is you treat with enough phosphorus, and you have to supplement usually magnesium. And actually, in cases where I think that there's refeeding possibility, we nowadays, if you just give phosphorus, like K-phos neutral, like 2 tablets, 3 to 4 times a day, and magnesium oxide, 1 tablet once a day, you can almost always prevent refeeding syndrome just by that. And if you don't have phosphorus, skim milk. Why skim milk? Nobody ever knows. I didn't know this, but it was discovered at the close of World War II when they first discovered refeeding syndrome, when they were releasing prisoners from Southeast Asia. And they started going, oh man, these people have been starving for months or years. We gotta feed them. So they started giving them food, and then the docs would go in 2, 3, 4, 5, 7 days later, these guys would be dead. Except the ones who were on skim milk. And the doctors knew that the difference between skim milk and whole milk was skim milk has more phosphorus. The amount of phosphorus in a cup of skim milk is equal to one of those tablets of K-phos neutral. And
I have a question.
yeah,
Will you elaborate a little more on what the refeeding syndrome is?
yes. I can actually have a slide on it that y'all will have access to. But basically what happens is as you start increasing the cellular activity because of the increased nutrition that you're starting, you switch to more of a carbohydrate metabolism, and that increases your insulin. Insulin drives phosphate into the cells but drops the serum levels, and boom, there you get it. That's supposedly how it works. I rely on my biochemistry people to tell me how it goes, but it's an interesting thing that happens. There are some other factors too, but I've got a more in-depth slide on that. On Monday morning, she showed up, all that stuff. We took her in, or they took her in, and bingo, this time she was 0.8 one more time. They missed it. They almost killed this patient because they refused. Can you imagine the lawsuit? This family would have taken them down, and rightfully so. I mean, this time they were admitted for 10 days, and then she got transferred to a specialty hospital that works just with severe eating disorders, severe medical problems. Quick review of diagnoses of eating disorders. Classic ones you've heard about: anorexia, bulimia, maybe binge eating disorder that you've heard of. Anorexia, restriction of intake, especially calories, but it can include subsets like maybe it's really protein, or it's fat, or it's carbohydrate. I've seen a combination of those, 2 or all of them. It can be purely calories. They don't care. They just, if it's over calories, they're not so many calories, they're not going to eat it. And one patient had baggies of 100 calories. It didn't matter what was in it, it was 100 calories. She'd have 4 of those a day, and that's it. She kept baggies of 100 calories. Didn't matter what it was in it as long as it was 100 calories. The other thing to remember is people who restrict food restrict fluids. They're almost all fluid restricted unless they're the other side and they fluid overload. Some of them will do that for a variety of reasons. One is to suppress hunger. Another one, I had one patient who was drinking 3 gallons of water a day. Now, what would you expect that to do? What would be the problem you'd be worried about? Electrolytes, 3 gallons of water, low sodium, hyponatremia. But she didn't have it because she ate a shaker of salt per day. Can you imagine how much salt that is? I mean, you'd turn into beef jerky if you didn't have a bunch of water. You'd just shrivel up like bacon. And so she was a water loader, but she was also a salt loader. All right.
How do people figure that out?
How do doctors figure that out, or how do patients? Don't know. Just something about taste. One of the things that happens with malnutrition is your sense of taste goes away or decreases. And so you'll have, they never used hot sauce before, now they'll put it on everything. Or I had one patient only drank pickle juice and vinegar. It was the only stuff she could taste that was liquid. And you think, oh, all the salt, but it was the only thing she could taste. And just like people who have anosmia and can't smell, they don't like when stuff you can't taste, and they don't have much of a sense of taste. As they recover nutritionally, that comes back. So that's one of the reasons, I guess. Who knows what started? I can never figure out in that patient what happened, why. Somehow. I've had some others who were salt loaders, but she was ahead of the curve. People with anorexia are malnourished, underweight. They can be pure restriction, or they may binge and purge. Now, binge to them may be something like 2 slices of apple instead of 1. And yet then they'll have to exercise or restrict more or purge or use laxatives, or diabetics will control their sugar. The first time I ever saw a diabetic with anorexia with purging features, she had not taken her insulin for 2 months. She was insulin dependent, and I asked her why. She looked at me like an idiot. She said, because insulin puts sugar into cells, and sugar makes fat. Really? I said. What else does it do? What do you mean? It also makes you hungrier and thirstier. Did you notice as your glucose goes up, you're hungrier? And that's something you don't want to have happen? She looked at me like, crap, he's right. That was the first day she had taken her insulin in 2 months. She finally got back on insulin. Fortunately, she did not go into DKA for some reason. But that morning, before she came in, she had a German chocolate cake, 2 dozen donuts, and a gallon of ice cream before her 9 a.m. appointment. And she had thrown up, I don't know, 6, 7, 8 times. But now these sound like really strange people, but I'm telling you, these are some of the sharpest, most engaging, empathic, intuitive, creative, hardworking people you will ever meet in your life. And I want y'all to keep that in mind. They may seem really out of sorts right then. You feed them a little bit, you start seeing what they're like, you're going to be impressed with who you get to work with. Exercise can be incredibly demanding. One patient ran in place 12 hours a day. Ran in place. 12 hours a day. Can you imagine? Another one, 16-year-old, was running 22 miles a day. She'd get up in the middle of the night, sneak out of the house, go run 22 miles before school. Drink half a cup of water before she left. Bulimia nervosa is characterized by binges, which is technically a rapid consumption of a large amount of food most people would not normally eat under the circumstances. So that would not be like going to Thanksgiving dinner or a tailgate party, or when I was telling them that one of us has a birthday party, these 3 friends of mine, we'll take the other, 3 of us will take the one with the birthday out for a Celeste Fest, and we go, get barbecue or something like that. That's not a binge. These are people who binge and they feel guilty, feel ashamed, they feel out of control. It is not like you go out and you have a feast. And then they follow it by purging. Laxatives and vomiting are the most common, but not necessarily the only one. Binge eating disorder is the same thing, but generally with not nearly as much compensatory behavior. They can have some, but not generally as much. Now there's these other eating disorders. EDNOS is what the DSM-4 has, and if you do the ICD-10 coding, are y'all learning that? No? Okay, well you will one day. So if you code, okay, what's the diagnosis? Binge eating disorder. There is no new ICD-10 for that. It's still eating disorder, not otherwise specified. So anyway, there's OSFED. Just came out, like other specified feeding or eating disorder. ARFID, avoidant restricted food intake disorder, and UFED, unspecified feeding or eating disorder. I am not a fan of those titles. I've not noticed any patients who like to be called somebody with RFID or OSFID or UFID. And I wondered, okay, if, wait, is that the, all right, where's, oh, there's, so if they have, wait, where did I go? There. So if they've got RFID, if they throw up, do they have BARFID? I mean, is that what we call it? Oh, well. No, really. I mean, because they will. So you're avoiding restricting, doesn't mean they can't. And it's important to know that many people will fluctuate from one eating disorder to another at times in their life. They can do that. So it's not like once an anorexic, always, or once a bulimic, or once a binge eating disorder. Without treatment, they can fluctuate. Even with treatment, they can. But from a medical perspective, what they do themselves or herself, himself or herself, is more important than whatever you call it. That I want you to keep in mind. Because when they're in there and you're evaluating them in the ER or in your office or a friend of yours or whatever, you're going to know, okay, what's putting you at risk? The degree of injury potential is related to the degree of behaviors. What if somebody throws up once a week? Is that a big deal? Come on, don't act like medical students. Act like you're engaged. Is throwing up once a week a big deal? Yeah, it would be to me. Once a year would be, once 10 years is too much for me. But you kind of think medically, is it a big deal? What if they take Ipecac syrup to do it? And what if it's after consuming 10,000 calories and they throw up and they're at risk of Boerhaave syndrome, which is esophageal rupture? That would then suddenly move it into a very serious. So that's what I mean. You got to look at it all in conjunction. And let's say you ask, well, how many times you throw up? Well, I only throw up twice a day. Okay, people who throw up once, like one or twice a day, they're not going to have electrolyte fluid problems, usually, unless you ask the question, and when you throw up, is it one episode, like you just, oop, and there it goes, or is it a session? And you will have people say, I throw up until nothing comes out. I throw up until my toes are hanging out my throat, something like that. Or until I can't anymore, until I pass out. I mean, all kinds of things. Those people are at risk of bleeding and all that other stuff. So when you combine all that, they're worse. But these eating disorders, and this is important, they're a combination of medical and psychiatric illnesses. So if you go to the psych hospital and you've got GI bleeding and electrolyte problems and EKG problems, what are they going to do for you at the psych hospital? Ship you to the medical. And there you are, and you've got an eating disorder, and they can't get you to eat, so what are they going to do? Ship you to the psych hospital. And they'll say, yeah, but from her GI bleeding, her hemoglobin 6, I can't take her because she's not medically stable. What do you do then? The hospital says, well, she's medically stable. But any treatment center won't take her because she's got a hemoglobin of 6. And now the guidelines, supposedly, from the hematology society or whatever, is that hemoglobin 6 doesn't require transfusion. Well, that's the assumption that you've got a normal bone marrow that will make red blood cells. Malnourished patients do not have that. So they get in this no man's land where nobody wants them. Or they may want them, but they don't have anybody who can do it. So I have told the psychiatric hospital in Austin that if you're going to call yourself a psych hospital, then at least say for everything except eating disorders, you need to put it on the sign. Because you took this patient and you were not treating her for psychiatric illness. And as a result, she got worse. It is important to remember that sufferers have impairment of judgment when it comes to weight, food, eating, exercise, and appearance. Denial and resistance are part of the disorder. So if somebody says, well, we're kicking out of our program because she's non-compliant, well, then close your program because they're all non-compliant at first, and you have to work with them through a transition. Therefore, they will not necessarily appreciate or agree with others' perspectives or decisions to limit exercise or increase their food intake or change their appearance or whatever. And this is something I want you to hear. All subjective comments about appearance will be interpreted negatively. If you say something like, you don't look like you've got an eating disorder to me. I had a patient who called, after that happened to her, she called hospital administration and all that other stuff. The guy nurse who was taking care of her was floored. He had no idea that he had insulted her or hurt her. She said that triggered her so bad. She said, I'm in the hospital and you're telling me I don't look like I have an eating disorder, like I shouldn't be here. And yes, she should have been there. She was severely ill. You just got to understand they're not going to accept you. You have to watch what you say. I know there's so much, yeah.
In fact, what do you say as patients are getting better?
Well, I talk to them about what is getting better, and not subjectively. I will ask them how they feel about it, how they think about it. What do you think about your appearance? What do you think about your weight? What do you think about all this? Why is that a problem for you? And if they ask me about what do you think about my weight, what do you think about my appearance, I said, well, why are you asking me? Do you notice you ask other people for stuff that you should know what's going on? Why do you do that? So I turn it back to them, make them process it. Say, okay, that's interesting. You asked me if you were attractive or if you think you're fat. Are you going to take a survey like 6 out of 10 that proves it, or you survey more people? You have to have your own internal sense of reference. That is something that comes through treatment. Now, I will tell them about their blood pressure, their pulse, things like that, and I also let them hear their heart, feel their I have them feel their pulse. I have them listen to their heart. I have them look at their hands and explain all this stuff. And I have them, as they get better, tell me what do they see that's improved. And they will notice it. And they will know that it's not accidental. And that those kinds of things do not set them off psychologically. Like, wow, haven't gained weight, but my heart's better. I like that. They'll do that. They'll say that. All right. Well, but eventually, if you're going to get more heart muscle, it's going to weigh something. So how are you going to handle that? So now here's something I don't know. How many of y'all know that the highest mortality rate of any psychiatric illness is in eating disorders? Higher than bipolar, major depression, schizophrenia, substance abuse. It's the highest of all. Combined, yes. Who said that? There you go. Very good. So it is not a mandatory, ACGME does not mandate in psychiatry, general psychiatry, or child and adolescent, does not mandate training in eating disorders. You're right now getting more training than 95% of medical students in the country, actually in the world. So, but lifetime mortality rates can equal or be higher than that of melanoma, prostate, testicular cancer, and almost equal to ALL. And the lifetime mortality rate for anorexia is 12 times the general population of females who are 15 to 24 years of age. So these are serious, life-threatening illnesses. You don't go to a treatment center unless you've got a life-threatening illness. You're that bad. And these general mortality rates is if you take all eating disorder diagnoses and lump them all together, how many die, how many don't. But if you have somebody like that first patient I presented with a phosphate of 0.8, what percent of those will die? It's a lot higher than 10 to 15%. She's lucky or blessed, maybe better, that she didn't. And she ultimately, by the way, turned it around and was thankful. She was fine with giving blood. She is eating now. I mean, a variety of things have happened. It's been a nice turnaround. She's still struggling. I mean, she's still in it, but so much better. Suicide is a big complication of this. About 1 in 5 will commit suicide. The longer it goes on or the older they get, increased risk of suicide. Malnutrition affects every organ system, nothing's spared, so clinicians should check for a dysfunction of all those systems whenever you like. All right, hold on, let me see. Okay, who's at risk? Anybody? Anybody in here? There was an article I read on the increased incidence of eating disorders in Afghanistan physicians. Google Alerts will send you all these articles from all over the world, and it's fascinating. I've seen it. No, it was Pakistani physicians. Excuse me. There was another one about increased incidence. A survey done of Iranian girls in high school that age who were taking the one of the eating disorder surveys, and something around 25% of them were testing positive for having an eating disorder. Now imagine trying to treat an eating disorder in a country like that. That can be very difficult, any of them. China has 1 eating disorder treatment center. Russia has 0. Many countries have nothing. It's really in archaic stages. You're lucky if you're in the United States in that regard, usually. Females have a 4 to 10 times higher rate than males. The youngest I've seen is 6. The oldest I've got right now is 67. They can go up even higher. There have been case reports of 5. When you start getting lower than that, now we're thinking, well, is that some other feeding issue that's not really an eating disorder? But other things, first degree relatives, if you've got a mother, a sister, something like that, a brother with it, you have a 15-fold increased risk of doing it yourself. If you have one, your kids have a 15-fold risk right there, just statistically. Doesn't mean they will, because there are protective factors. These other things where appearance is important can make a difference. Higher rates of eating disorders in those, and athletes especially, can be. Models, and that's male as well as female. Had a guy who was a male model up in New York. He said he didn't know a single guy who wasn't purging to try to stay with the physique so that they could have for like Abercrombie and Fitch. Sorority members, why? Because of rush and what they tend to feel, people feel like they're being judged on, appearance more than other stuff. Vegetarians and vegans, that you may hear a lot about this, but if you've got an eating disorder, anytime you start to restrict somebody's intake, you have to be careful what you can set off. Very careful. So many people who are, for whatever reason, reason or another, if they're a setup for an eating disorder, and we can't tell who that is, if you restrict their intake for anything, it can be appropriately for, let's say they've got celiac disease. They have true celiac disease, not pretend celiac. Or if they've got diabetes. People who have diabetes have a higher risk of getting an eating disorder. People who have restricted because they've had dental surgery, oral surgery, who've had something else that made them sick, a illness when they did travel to another country or something like that, that can set it off, just right there. I had a patient whose house burned down. And literally, the family rushed outside. All they had was what they were wearing, everything they lost. The next day is when the girl started restricting. Things like that can set it off. So vegetarian vegans, that can do it, because you're starting to reduce your protein source options, and you may reduce their calories as well as protein, and that can trigger it. So what is the big mantra now for the obesity epidemic, especially childhood obesity? What do we tell people to do? Eat less, exercise more. All right. So since the 1960s, we know that if you take rats and you put them in 2 sets of cages, and one set is your basic wood shaving and water, and the other one is wood shavings water with a wheel that they can run on. And you restrict the intake to a level that over time is not enough. And you watch the behavior of the animals. In a state of decreased energy reserves, animals will naturally tend to sleep more, move less. When they move more slowly. Makes sense. You're saving energy. You want to stay alive. What do these rats do? They run. They run compulsively. And there's one study where they started measuring how far the rats would run a day, and it can be up to 10 kilometers in a day. And they run fast and hard, and they will run until they die. putting food in the cage did not change the behavior of the rats. You had to eliminate the wheel or take the rat out of the cage and put it in one that did not have a wheel. So what does that sound like? When we tell people, okay, we want you to eat less and exercise more, that's a great sounding thing. How successful is that? In the studies done on caloric restricting diets, what is the average weight change after 4 years? Up, down, stay the same. Goes up about 5 pounds. 95% of people who undergo that will gain weight in 4 years as a result of the diet. Name one thing in medicine that we recommend that has a 5% success rate and a 95% rate of making you worse. If you had a drug and say, hey, I got this great drug, 5% of the people are going to do okay on it. 95% will get worse from the very thing we're trying to treat. And yet, it is what we practice and preach all the time. The problem is you don't know who that message is going to send down one rabbit hole versus some who are going to be okay with it. You just don't know. Vulnerable populations, like a list here, are ones you have to watch out for. The very people you think should be at lower risk tend to be the ones who are at the highest risk. The A students, the smart, the intelligent, creative, hardworking, gifted, talented academics. This eating disorders, as a group, will be the most empathic people you'll ever meet in your life. It's almost like if I meet somebody who's so empathic, I'm thinking, okay, do they have an eating disorder? And if not, how come? Because they fit the bill. They're really incredible people. So if you look at younger populations, there's females 14 to 16 who had a history of severe dieting, which would include very restrictive intake, had an 18-fold increased risk of developing an eating disorder. And it does not matter if they were obese or morbidly obese. I had a patient who was 220 pounds with anorexia. How could that be? How can that be? Because you're looking at one point in time, what was she before? 440 pounds. In the last 2 years, she had lost 220 pounds, 110 pounds a year. You can't tell. You take an athlete, and when you talk to athletes who have developed eating disorders, I don't know if there are any swimmers in here, but Dara Torres had an eating disorder, and she was 25 years after she set her first world record, she set her last. Amazing swimmer. She was predicted to be the Michael Phelps of women's swimming. Never did it. And the reason was she had an eating disorder. And she said it started on the side of the pool. Another guy from the gold medalist swimmer from Australia said the same thing. The coach started weighing us on the side of the pool. I decided to go run. Because I need to get my weight down, I guess. And boom, set it off. And he had to retire from swimming. Lots of people have gone through that. Dara Torres, when she went back at the age of 39, I think it was, to the Olympics, it was after she had gone through treatment and then started training again. So, but the young ones so when you see somebody young and it sounds like they're restricting, I want you all to think about this. 25% are male. So if somebody says to you, well, it's very unlikely this is for women, for girls, not for the younger ones. Most of my younger patients, 7, 8 years old and so on, have been males, the majority. But in this study, 25%, that's completely different from what you would see from older. Most were admitted to the hospital. Only a third of them met the traditional criteria. Only half met weight criteria, yet 61% had life-threatening medical conditions upon the first medical visit. So these are pretty big deals. They can be wolves in sheep's clothing. Now, I talked about what kind of people get eating disorders, and I know everybody in this room knows somebody with at least one person with an eating disorder, whether you know it or not, even if you didn't have one. But Are these people you would think of as crazy idiots? Now, some of you may have seen them exhibit crazy behavior, but these are all people. Any of those names you not recognize? Were y'all, any of y'all Spice Girl fans? 3 of the 4 were, right? Weren't there 4 Spice Girls? I think. Anyway, these 2 died. Amy Winehouse died. Her brother said it wasn't the alcohol, it was the eating disorder that killed her. And he donated a lot of money to the British Eating Disorder organization. Karen Carpenter, the first famous person to ever die from an eating disorder. All these people, that's all from American Idol, Sisters, you know all them, and so on. Dennis Quaid, Billy Bob Thornton, Dennis Quaid called it his manorexia. And if you've ever seen pictures of Christian Bale when he was Batman, very fit guy, look, right? Then you saw him in American Hustle. What did he look like? He gained like 50 pounds. Anybody see, what was it, the mechanic or machinist? What did he look like? Skin and bones. In fact, they had to stop production because he had lost too much weight. And with Dennis Quaid, it started when he was in a role where he had to lose weight. Matt McConaughey just went through that, and I don't know if he's recovered or not. I have no idea. I didn't say he has an eating disorder, but I was worried about him because for the role that he was playing of somebody with AIDS, he lost a lot of weight. And I know he did that because he's from Austin, and he worked out at this gym, and he worked out a lot, and that's how he did it, which was very dangerous. So here's another one. These are all other people. Now, these are some incredibly talented people. Nadia Comaneci, first person to have 3 10s in gymnastics. And she was 5'1" during the Olympics when she set those, and she is now about that tall. She's about 5'10". And she developed an eating disorder. After that, her coach used to keep them on 800 calories a day as gymnasts. Now imagine it. So can that trigger it? I would say yes. It can. Did it? I can't say in her case. So if you haven't seen the American Journal of Eating Disorders, just go to your local grocery store, and then when you go through the line, you pick up a People magazine. Almost always there's some article about somebody with an eating disorder, movie stars and their weight and all that. So I call it the curse of the blessed. All right, let's see what happens here. An 18-year-old was followed by her therapist and a dietitian for 3 months prior. Then recommended to go to inpatient treatment. She was at a psych hospital 200 miles away and there for a week, and then she was told to go to a medical hospital and was discharged without a direct referral or transport. She went to Austin Hospital, was hospitalized for 4 days, then released a week before she came to see me. And then when she came in to see me, she was 5'3" and 73 pounds with her clothes on. A week before, she was 84 pounds in the hospital. And 7 months before, she was 133 pounds. She was an A student. Her weight changed from a BMI of 70, or a BMI changed from 72% to less than first percentile in 7 months. Her temperature was 94.1. That is all, actually all you need is the BMI graph to know that this person needs to be in the ICU. I don't care who saw her before, she's not safe. Then she has a body temperature of 94.1 degrees. She was so cold, I knew as soon as I shook her hand she was going to the ICU. A 4.5, almost a 5 degree lowering of the body temperature is the same amount of heat you save, the same amount of heat that you burn if you have a high fever, 5 degree fever. That's a lot of heat that you're saving. Her pulse was 80, blood pressure 88/70, a weak 42 pulse. Couldn't hear her blood pressure when she stood up. She had a thready, weakened, and biphasic pulse. How ill is she? Does she require hospitalization? And when should that seriousness have been detected? So I'm counting on you people to be the ones who are not going to be people who forget this stuff. and lose your brain when somebody says they have an eating disorder. You become decorticate and you just start treating them like they're somebody you want to get out of your emergency room. These are complicated illnesses. She had temporal waste. She had the same kind of stuff before, except she had deep cyanosis all the way to her inguinal ligaments. You have done, I don't know if y'all have done any codes, but when you do codes, you're not going to see people that deep of cyanosis that she had. It was dark. It was basically like a blue jean color is what her skin looked like. And when I asked her to do the serial sevens, y'all know what that test is, where you start with 100. I want you to subtract 7 and do it as accurately and quickly as you can. And whatever number you get, I want you to subtract it again. I say, for example, if I told you to subtract 5s, you go 195, 90, 85, 75, 85, 80, 75, 70, 65, 60, and so on, as fast and accurately as you can. Here's what she did. I said, start at 100 and subtract 7s. 103, 93, 87. That's as fast as she could do it. And notice that she started repeating the pattern. She was perseverating. Severe cognitive dysfunction due to her malnutrition, and yet this was a very gifted student. Notice the lab here. White count was 2.1. Red cells were low. Hemoglobin was low. Her platelets were 1/10 of normal. And her glucose was 49. I don't know where y'all are in your training if you know that, but that's very low. If any of y'all had a 49, we'd probably be having seizures in here. But she was used to that. And what organ systems have been affected in her? Everything from her brain to her guts to her endocrine system to her bones to cardiac, respiratory, you name it. Very seriously ill. She also developed refeeding syndrome in the ICU, and she had to stay, gosh, I forget how long she was in the ICU, like a week, something like that, and she had to be tube fed. They were going to take her rights away and do it for her. If she didn't, I was able to talk her into accepting the tube feeding, and that helped her survive and then move on. A soccer player. Now, this is something, if you ever see, you'll say, I've heard about that. She looked fine. She had dropped her weight some, but she looked okay. She looked still pretty athletic. Didn't look muscle wasting or anything like that. Was acting normally. And again, a straight A student, but her blood pressure was 90/30 and pulse was 38. And it was 32 on the EKG. And standing up, she went to 68. So if you just measured her heart rate sitting up, you may go, well, it's like 50. That's a little low. You lay her down and you go, oh, okay. Now what happens at night? How low does her pulse go? Well, I'll tell you in a minute. The lab called me the next day on Saturday morning, said we have an alert lab value. She has no glucose in her blood. They tested in 2 machines, recalibrated the machines, no detectable glucose. I've had 4 patients now with that. That's a big deal. So anyway, she got admitted for 3 weeks to the cardiac care unit finally, and her pulse dropped in the low 20s at night, could not be transferred for 3 weeks because we couldn't get her heart rate up to 40 until after about 3 weeks of tube feedings. So here's some of the stuff I want y'all to know about. I'm going to move on. Here's a BMI graph of a patient, a 14-and-a-half-year-old. In less than a year, a little less than a year, she crossed every line on the growth curve. The steeper you see the BMI graph, the more likely they are to be in very serious cardiovascular condition. And when I tell people and I show them this, the parents this, and the patients, I say, okay, now if you're flying Southwest Airlines and that's your plane, what do you want the pilot to do? Pull up. How soon? Now. I said, and I tell parents and I tell patients, that's what's got to happen right now. We got to pull up or you're going to hit bottom. Okay, I'm going to go into some other stuff because of the lack of time. That's what I'm talking about, capillary refill delay. And this is not where I'm squeezing her hand. It's just like this. I go like that, go like that. And you can see the blanching that she does. And this is her doing it to herself. And here's that palmar capillary field delay, and I say, okay, squeeze yours. And when I open mine, here, everybody do it. Squeeze your fist. And when I open mine, I want you to open yours, and I'll tell you how fast mine comes back, and we compare. Ready? Go. Mine's back. If it's longer than about 2 seconds, now sometimes if you're cold and cold air or whatever, it can make it a difference, but 10, 15, 20 seconds, something's up. It's a great way to say, okay, why is your heart not able to perfuse your fingers? If you're a young adult and you're an athlete. Here's on the toes. Here's, you can see the color of my hand versus the patient's hand and feet. Here is some pedal edema you will get from the hypoproteinemia or from refeeding syndrome or from something called pseudo-Bartter syndrome as a result of this. And here's another view of it. And here's pretibial edema from pushing on it. Now this is what would you guess her BMI is? Normal? And that? She actually had a 13 BMI. What you're seeing, why she looks pretty full in here, that's all water. When she walked or she went like that, you could hear bloom, bloom, hear water slosh in her abdomen. She was so hypoproteinemic, water could not stay on gravity. It leaked out into the third space, into the abdomen. That's called ascites. What do you notice on this? Anybody know what Russell's sign is? You're being introduced today. Russell's sign, Russell was the first guy to ever describe bulimia and talked about cuts and calluses on the knuckles. Right here, this is a soccer player who, first person I ever saw with a really low glucose in my office, and all she said was, I'm feeling really hot. It was a 28 glucose. But you also see she's a little bit nervous here. Now here's one. Can you tell me two things here. What is her diagnosis? What kind of eating disorder does she have? And is she left or right-handed? You should be able to tell from this. All you Sherlock Holmes, Dr. House.
Left-handed.
Okay, left-handed. How do you know?
Because she would stick these fingers down.
Yeah, because you can see the callus right there. What diagnosis, what eating disorder would you say? Take a guess. Come on, y'all. Don't be shy. Come on, throw it out there. Bulimia. That'd be a good guess. Except, does she look overweight, normal weight, or underweight? She's got metacarpal wasting. Here, so she has anorexia nervosa with binge purge features. She's a purger. And she's got anorexia. She has muscle wasting, even in her hands. Okay. Hypoglycemia, let me just tell you real quick. Glucose, here's the deal. Your brain only uses glucose. Remember the MCAT test? I have suppressed a lot of that memory. But I've had to take board exams and felt the same way, I guess. But I remember after SATs in high school, I walked out of there going, oh, I got a headache, and I am hungry, and I want to go to bed. Why? Because your brain uses 60% of your glucose at rest. Glucose is by far the preferred fuel of your brain. Neurons cannot store glucose. For your brain to work, it has to have a constant supply, not an intermittent, constant supply of glucose. So when your glucose starts to drop, how does your body keep your glucose level back up? You have glycogen, which is the stored glucose, big stores in your liver and your muscles. Muscles is what you use for the first 30 minutes or so of exercise, glycogen, but you can also have your liver do it. But what if you've been living a life where you're not getting enough calories and you start burning up all your glycogen reserves? Then you don't have glucose to buffer that, so you can get really severe hypoglycemia. But also, what does your brain do? There are two other fuels that your brain can use. One is ketone bodies, which is a breakdown product of fat. Do you think that last patient with the knuckles, do you think there's much fat in her diet? Or in somebody who runs 22 miles a day, do you think she gets enough fat in her diet? No, anorexic, no. And there's not enough fat on her body to use, So, oh, and by the way, ketones will suppress hypoglycemia. You won't know it. If you're using ketones, you may not know you're hypoglycemic until until you have a seizure. So the last thing, and I don't expect anybody here to know it, but it's lactic acid. How do you make lactic acid? Come on, biochemistry 101. Okay, under what conditions? Anaerobic, not enough oxygen. So how do you create that to feed your brain if there's no glucose or fat? Exercise. So these severe exercisers are probably feeding their brain by exercise. And the other way is, remember the blue hands and feet? That's anaerobic oxidation going on there. There's not enough. That's why it's blue. You're actually producing lactic acid that may be feeding your brain and keeping you alive, keeping you from having a seizure. And the problem is, if you have to exercise to feed your brain, then you've got this heart-brain conflict. Who's going to win? Who's going to lose? You want both to win. You don't want both to lose. If one loses, they both lose. So one of the other things, and I asked the head of cardiology at Johns Hopkins, who's a William Osler professor of cardiology, nice guy. And I said, okay, my patients run these low temperatures. And he had just given a talk on the new information about CPR. If you can lower the body temperature of the person you're doing CPR on, even 1 degree, you improve outcome. Notably, measurably improve outcome. I said, so if you lower their temperature 4 degrees, what happens? And I said, on these patients, do you think one of the reasons they have hypoglycemia is actually to help hypothermia is to protect their heart? And he said, let me think about it. And he came back to me about an hour later, I think you're probably right. That's probably why they do it. Of course, that's not something we're ever going to do a study on. So I'm going to go over some other stuff right here. Yeah. Yes. One last thing here I want to talk about is I want you to think about when you see patients, young adults, children or whatever, be really careful when you talk about body fat, weight, anything like that. You can be the instrument, and this has happened to people in this room and their families. A physician can say the wrong thing and set it off. Your BMI is too high, we need to put you on a diet. Boom. And then you set off a life-threatening illness just because this is somebody who's a straight A student, gets into running and all that, and now their eating disorder is engaged. It costs the family $100,000, and the patient still 4 years later is fighting an eating disorder. Set off. Yes.
My name is Fran. I'm a parent and so I know a lot of people, parents in this odd community of eating disorder world. And one friend of mine, I mentioned this to Dr. Tyson earlier today at lunch, her middle daughter had severe restrictive anorexia and is now thankfully doing very well now 3 years later. But normally she takes her 3 kids every year for their yearly checkup. Does it right before school starts. This year she wasn't able to do it, so her husband did it this book, and she wrote to me that on, I think it was Monday or Tuesday, they went for their checkup, and her youngest boy, who's 9 years old, about to start 4th grade, happy kid, loves to run, always with a ball, loves his dog, just a good,
Regular kid.
great kid, yeah, great kid. The doctor, this never would have happened had Celia been in the room, but her husband took the kids and for their checkup, and the doctor said that Alex, the son, is overweight. He needs to lose weight, and he said it in front of the child. This was just a couple of days ago,
Right.
beginning of the week.
Yeah.
And he shouldn't have more than 1 cup of Cheerios a week. He started, more exercise. This is a kid that's already playing, all
Yeah.
the time. also knows what the family's been through with their daughter. And so she had a talk with him, her son, and thought everything was okay. And then 2 days later, she sent a picture. She found a banana in the bathroom trash. And that's just how quickly words.
So why was the banana in the trash? What's the assumption? That he shouldn't have
Just
it.
given that as a snack,
Mm-hmm.
and just don't eat it.
Yeah.
It's just that simple.
The doctors
Maybe
know.
wait till dinner, or I don't know what he was thinking, but
Right.
yeah.
You'll be very powerful in your recommendations and the things you suggest and say. Be careful around fat food, figure, and fitness, because you will set off a firestorm in somebody.
And if I could just share one other story that happened to my daughter when she was 19 and away at college, and she had gone for a checkup. Her cholesterol was high. I don't know what the numbers were, but it was considered high. And she had taken herself to the doctor. Her skin was already starting to sort of turn this orangey color. She was getting the
Lanugo. Mm-hmm.
starting to show up on her face. Her nail beds were starting to get bluish. And although I wasn't there, she was about 1,500 miles away. And all the doctor said to her is her cholesterol is high, and didn't explain anything else beyond that. So she was already only eating maybe 2 hard-boiled eggs, egg whites, no yolks, a little bit of non-fat yogurt, lettuce, carrot sticks, and an apple. And that was her diet. Plus, she ran about 6 miles a day, down from the 10 or 12 she was doing. She started not to feel well. And what she heard when he said, "Your cholesterol is high," she started to think, "What can I eliminate from my diet to get? Why is this?"
Yeah.
People. I later, learned that it was one of her organs, I think her liver, that was being affected by this.
Well, I'm sure she was actually having autophagy where she was eating her liver. You'll see elevated liver enzymes because they start eating your liver, and you're having pate for lunch. The trouble is it's your own pate. But what happens in a state of malnutrition, you can actually synthesize cholesterol. It will look like you have an elevated cholesterol, and something like this completely missed it, that this is elevated cholesterol because she's not eating any cholesterol. And you have to have cholesterol molecule as a base for what? Hormones, for example. So that can happen. So just all the talk, now you're going to be doctors, and it's your role to rise above the craziness about this stuff. Use common sense and be cognizant of how powerful you are and what your words may set off. The primum non nocere, that above all do no harm. Be careful what you say. Be mindful. How is this person going to receive what I'm saying? How would I like to hear this from a doctor? How would I like to hear this as a 13, 15, 16, 40-year-old from a physician? How should that be handled? And is what you're telling them going to be helpful, harmful? Is it going to be based on science or based on, well, I don't know what else to do? So I want y'all to just be cognizant of that. Another thing I want to say real quick is avoid all comments about appearance. There are no bad foods. When you hear people say, well, I'm having healthy foods. I'm eating healthy. The most common thing that happens that brings patients into me is they decide they'd exercise and eat healthy. So what's healthy food? Oh, well, it's like that. That's healthy. No. Healthy is what it is to give your body whatever it needs. It doesn't have to be food brought down on the back of a yak by a Buddhist monk from the top of the Himalayas to be something that's good for you. Your body is going to use its enzymes and stuff, and it's going to put gastric acid and all that stuff, everything in it. And what it digests, when it goes across the membranes, it's going to be the same molecule that it was no matter where it was from. You have to take in what you need. Keep your balance of exercise and food, all of that. It's got to be a balance. They have to have enough for each. And so y'all have been more than patient to come in on Friday, and I appreciate it. And I guarantee you're going to see this in your own family, in your friends. My daughter came home one night in 8th grade, started bawling at the table about one of her friends on the volleyball team, who she said, we've tried to get her to eat more and eat more and eat more, and we can't. You're going to see it around you. And when you treat someone like this, these are going to be some of the most devoted patients you will ever have in your life. They will love you for what you did that nobody else did, and make you feel like, that's why I went into this field. I want to help people in this regard. Nobody else is out there. So I wish you luck in your further training. I used to help teach at the DO school down in Tulsa, by the way. I was on faculty there as an adjunct and really enjoyed those classes. You've been more than patient today. Thank you. All right.